All right, so discussing the risks, benefits of gender-affirming hormone therapy. This is a little bit small print for me to read. I may have to move kind of closer there. Let me get the mic, and I'll move a little closer to that screen.
I think if you animate it, the sort of highlights come up.
Let's see. Yes, so timeline here. So timeline, this is so important because when our patients come to see us for hormone therapy, they want the effects right now. They want it today. They wanted it yesterday, okay? They're very eager to start hormone therapy to get the effects. So it's really important to set the expectations. So I often tell patients that, you know, the average cisgender person went through puberty over a course of years, not days or weeks or months. And it's very variable depending on the organ system as well. And so there can be actually very subtle changes to the voice with low-dose testosterone within several weeks, whereas changes to, you know, facial and body hair, for example, can take over a year in both transmasculine and transfeminine patients to see a lot of effects. And so that's one big issue here is timeline. What changes, what doesn't change. And again, I always like to emphasize there's so much individual variability in this area. So it depends on your genetic background. So if you come from a family where all your relatives don't have much body hair, you're probably not going to get a lot of body hair if you get on testosterone. Or if you're from an ethnicity culture where there is where there is much more body hair, you're probably more likely. Same thing with breast development and other features here. Same thing with the androgenetic alopecia. So this happens in individuals who were genetically predisposed to it. So not every transmasculine patient who gets on testosterone would get the alopecia, depending on their genetic background. And what is permanent, what is not. This is really important, okay, because this is a big decision, pulling the trigger on whether to start hormone therapy. People have to know what they're getting themselves into, particularly with the explosion of non-binary patients within the last few years. There are a lot of patients who are contemplating hormones. They may want to get on hormones temporarily, kind of take them for a certain duration, and then they get an effect and then stop the hormones. So they need to know what is permanent and what can go back to baseline. And effects on fertility. There's going to be a lot of sessions on this. There's still a lot that we don't know about this topic. My kind of go-to lines that I tell trans feminine patients is I say that that long-term high-dose estrogen use can suppress sperm production, and you'll likely not be fertile if you were on the hormone therapy. However, there was a very interesting study from Germany where they looked at trans feminine patients who had orchiectomies, and they had 3 different groups. One of the groups, they said, continue your hormone therapy up to your orchiectomy. Another group was told to stop their hormones 2 weeks before, and another group stopped 6 weeks before. In the group that stopped their hormone therapy for just 6 weeks before their orchiectomy, half actually had normal fertility. So it is still possible for a lot of trans women to be fertile if they were to come off the regimens, but we can't predict. Now, in actuality, what we tell our patients, if you're interested in having a biological child, the safest thing to do is just sperm bank. Now, put that away so that in the future, if you need it. On a practical level, though, I can tell you, because this is part of my standard template, I always ask patients, are you interested in having a biological child? And I would say at least 90 to 90% will say no right out. And for the ones that are interested in having children, they're often very happy with adopting. So it's actually very rare that I get a patient who said, yes, I want to have a biological child, and it's usually more if it's a 19 or 20-year-old and the parents in the room, and it's more the parents' concern than the 19 and 20-year-old, because usually having a child is not on the first kind of thing in your average 19 or 20-year-olds. So I'd like to open it up to the panel to get their other perspectives about timeline changes, permanence, and effects on fertility.
But I think that's the point, and it's reversible. So when you stop, you stop, but at least you have conversations with people, and you can talk about other ways of improving bone health. So, I mean, I'm not so cut and dry as like I'll never do it. What I would never do is use bicalutamide, though. And I'm just, that's me. I liked what you said about like not using you're doing your own like little experiments, n equals 1. I mean, the issue with bicalutamide is that this is not a dose-related adverse effect. These are kind of idiosyncratic effects, and when you've had someone die of hepatic necrosis, I guarantee you, you're not going to be reaching out for that so quickly again. And it's important that we talk to our clients about the lack of evidence before we start throwing medications at them that are potentially incredibly dangerous. And maybe I'm the only one here that says that, but I had a person die of this, and I will not be reaching out for it. I didn't start the medication, but when they came in and they were already jaundiced, it was too late to get them a liver.
So this is bicalutamide, and so this is an anti-androgen historically used for the treatment of prostate cancer, although it's not currently being used too much. But there's been, as we've spoken about generally with some other medications, there's been a lot of stuff on YouTube. There are certain people that are kind of proponents. So we very commonly get asked these questions: what about bicalutamide? What about this? I've heard about this. I've heard about that. And so we need to have our answers ready and prepared. I did a literature search on bicalutamide, and I came up with one. It was a randomized controlled trial done in men in prostate cancer, but I wasn't that impressed with the sample size of it. It was only a few hundred men, which means that it's underpowered to detect some of these. And with you telling me that you had a patient develop liver failure, which could be a life-threatening thing, and I'm not sure if that's another case that I read about, that would also give me reason to pause and say, listen, this is really an area where it's unfortunate that there are some people kind of promoting all of these treatments and meds without doing the studies, without getting that first. I would encourage all of these people on the internet, that are prescribing these, publish their data, follow their patients. I mean, some data is better than no data, even if it isn't going to be great randomized controlled trials, because there's so much we don't know. And safety and efficacy are the two most important things that we need to evaluate. And in so many of the medications, we just don't know that. And one of our major goals as physicians and healthcare providers is to do no harm. We really don't want to do something just because they heard it on the internet and that, oops, they died. Oops. This is really bad and tragic.
Yeah, I mean, to me, it's that tension of patients who, are in an area where they have not had trust in the system and are trying to educate themselves, and then, but out there, the internet is fraught, and it's part of the beauty of this room, honestly, is having conventional medical folks really thinking in conventional medical ways, and being very patient-centered, but still protecting our patients from accidentally experimenting on themselves or putting themselves in harm's way due to some fad.
Finally, there was one slide, and there's very little discussion about androgen receptor blockade with bicalutamide. A reason for that, it was a prostate cancer drug available in the U.S. where no cyproterone was available, and no data about it. I do think if you were starting today in designing therapy, you'd have a serious look at custom designed androgen blockers like bicalutamide in a controlled sort of trial, and I think it probably deserves a look. The risks for liver, which are quoted on the slide, if you actually look at the numbers, I was checking again, abnormal liver enzyme tests are less than 1%. Serious liver trouble is much, it's like 3 less than 1%, so you're in the 1 to 10,000 range perhaps. So it probably has a better safety profile. Nobody knows. Some folks are talking about it. That's where it comes from. So that's a really long answer to that blockade, but it's something you just have to be ready to discuss because it's out there. And what I commit to do is is try spironolactone, cheap, effective. Most people are fine. You don't like it, then we can talk about some of these alternatives.